Hello friends, today I am going to discuss treatment of community-acquired pneumonia. We often come across patients getting admitted or seen in the clinic with community-acquired pneumonia. Often these patients present with fever, cough expectoration and chest pain, and X-ray will show signs of infiltration either in one lobe or more than one lobe. Once we make a diagnosis of community-acquired pneumonia, how can we treat them or manage them based on this guideline? The most important strategy at this point will be to decide whether the patient needs in-hospital admission or not. That means we can broadly stratify patients into those patients who can be managed as outpatient or patient definitely need hospitalization. The most important decision to make whether the patient can be treated as outpatient care will be their ability to take oral medications, have adequate outpatient care. Patients who cannot take oral medications and do not have adequate outpatient care, or they have severe pneumonia based on curb 65, two or more on curb 65 pneumonia severity index assessment, or other prognostic models such as pneumonia severity index or physician's professional judgment suggesting patient needs an hospital admission, they are admitted. curb 65 includes confusion, uremia, respiratory rate, low blood pressure, and age of 65 years or older. So those who has curb 65 2 or more score needs hospitalization or aggressive outpatient care. Once we decide patient needs in-hospital admission, then we have to decide whether they can go into the general ward or need an ICU. Straight away, patients will be admitted if they had presented with septic shock necessitating vasopressors, or they have acute respiratory failure requiring intubation and mechanical ventilation. We also need consideration if there are three or minor criteria for ICU admission. These include hypothermia, PaO2 FiO2 ratio less than 250, leukopenia, multilobar infiltrates, confusion disorientation, respiratory rate more than 30, blood urea nitrogen more than 20, thrombocytopenia, hypertension requiring adressive fluid resuscitation, and other consideration like hypoglycemia, alcoholism, hyponatremia, unexplained metabolic acidosis, elevated lactate cirrhosis, or asplenia. So if there are three or more minor criteria, again they need admission to the ICU. We mentioned about this patient who will be straight away admitted to the ICU if they need invasive mechanical ventilation or septic shock with recurring vasopressors. So once we decided, okay, this patient can be treated as outpatient, we again have to give some considerations like the patient has to be previously healthy and should not have any risk factors for drug-resistant strep pneumonia, or they should not have taken any antimicrobials within the last 3 months. In this set of patients, we can treat them as outpatient with macrolide. Preferred macrolides are azithromycin, clarithromycin, or erythromycin. If they have any issue with macrolides, then alternative option will be doxycycline. But again, we decided to treat them as outpatient and they are fit for outpatient treatment. But in a subset of patients who has comorbid illnesses like diabetes, chronic heart, lung, liver, or renal disease, alcoholism, malignancies, asplenia, immunosuppressive conditions, or medications that suppresses immunosuppression, or antimicrobials in the last 3 months, or risk factor for drug-resistant strep pneumonia infection, then they cannot be treated with macrolide, but instead of that, they should be given respiratory fluoroquinolone as outpatient. Preferred respiratory fluoroquinolones are moxifloxacin, gemifloxacin, or levofloxacin. Or if you don't want to treat them with respiratory fluoroquinolone, you can treat them with beta-lactam plus macrolide. Preferred beta-lactam at this stage will be amoxicillin or amoxicillin clavulanate or cefopodoxime or ceftriaxone or cefuroxime. Macrolide will be azithromycin or clarithromycin or erythromycin. Alternative to macrolide are doxycycline. Okay, now we are going to describe a set of patients who needs inpatient empirical treatment for community acquired pneumonia. So again, if these patients do not need ICU admission, then they can be treated with respiratory fluoroquinolone or beta-lactam plus macrolide. Preferred beta-lactams are cefotaxime, ceftriaxone, or ampicillin. In certain patients, ertapenem can be given. In patients with penicillin allergy, they can be treated with respiratory fluoroquinolones, which including moxi, levofloxacin, or ciprofloxacin. Okay, now let's discuss about patients who needs ICU admission. The minimum antibiotic requirement, empirical antibiotic required for ICU admitted patients with pneumonia are beta-lactam plus either azithromycin or fluoroquinolone. Preferred beta-lactams are cefotaxime, ceftriaxone, ampicillin, sulbactam. Patients with penicillin allergy need to be treated with the fluoroquinolones and aztreonam. In patients who are admitted and we suspect Pseudomonas infection, they have to be treated with anti-pneumococcal anti-pseudomonal beta-lactam, including either piperacillin, tazobactam, or cefepime, or imipenem, or meropenem. In addition to anti-pneumococcal anti-pseudomonal beta-lactam, they have to have either ciprofloxacin or levofloxacin. Other option will be beta-lactam plus aminoglycoside and azithromycin. The third option will be beta-lactam plus aminoglycoside plus anti-pneumococcal fluoroquinolone. In patients with penicillin allergy, they can be substituted with aztreonam. If you are suspecting community-acquired methicillin-resistant Staph aureus, you need to add vancomycin or linezolid. In addition, these patients needs treatment considerations such as local resistance patterns of antibiotics, previous antibiotic use, comorbidities when choosing empirical antibiotics. Patients may need non-invasive ventilation in case of hypoxemia or respiratory distress unless they are getting intubated and mechanical ventilation. We prefer low tidal volume ventilation for patients with diffuse bilateral pneumonia or acute respiratory distress syndrome. Patients need to be screened for occult adrenal insufficiency in hypotensive fluid-restricted patients with severe community-acquired pneumonia. How long we should treat and when we should start the treatment. If possible, the antibiotic dose should be started in the emergency department itself and should be given within 6 to 8 hours of presentation. Minimum duration of treatment should be 5 days, but give consideration if the patient had were febrile for within 48 to 72 hours and they don't have any community-acquired pneumonia, so the signs of clinical instability before discontinuing therapy. Longer duration of treatment may be warranted in certain circumstances, like we gave the antibiotic which are not targeted to identified pathogen, if they have extrapulmonary infections such as meningitis or endocarditis. We can consider switching IV medications into oral in hemodynamically stable patients with notable clinical improvement, normal functioning gastrointestinal tract, and they can ingest oral therapy. Usually, we switch oral form and IV antibiotics to same form of oral antibiotics or having same pharmacological class. They can be discharged once patient is clinically stable, and then they do not have active medical problems and have a safe environment for continued care as an outpatient. Clinical criteria for clinical stability in community acquired pneumonia are temperature less than 37.8 degree, heart rate less than 100 beats per minute, respiratory rate less than 24 beats per minute, systolic blood pressure more than 90 millimeter of mercury, arterial oxygen saturation more than 90 percentage, or PO2 more than 60 millimeter of mercury, and they can maintain oral intake and normal mental status. These guidelines are based on Infectious Disease Society of America and American Thoracic Society Consensus Guidelines on the management of community acquired pneumonia.